Okay, so to wrap up GIT, we are basically just left with the pancreatic pathology. So let's take a look at what we have for that. Okay, we talked about all of these things. Now we're just going to be looking at the remaining issues of pancreas and pancreatic cancers. Now, this topic right here, insulinoma as well as VIPoma, those were discussed in endocrine back in step 1. Right? So insulinoma was one of the things that actually occurs in men 1, right? As well as many other pancreatic cancers that can occur there. So this results from insulin-producing tumor associated with men type 1, usually benign. And this is actually not talked in much depth in step 1, but when I was learning it, that was kind of when UAssembly RX, as a company that makes videos, was pretty new, and they were the ones that actually gave me my idea to make the videos I made, because I kind of wanted to do a better job than they did in those videos. And they talked about it a lot. So this snippet right here is actually from their lecture in UAssembly RX videos, where they were basically talking about how usually when someone has excess insulin because they might have injected too much, or they injected insulin but then they also ended up working out a lot or didn't eat, right? So either way, the amount of insulin they needed was more than the amount of sugar they're having in their body. Usually when that happens, the symptoms of hypoglycemia are not so bad. So usually some people that get hypoglycemia will tend to stay around this barrier between red to green, right? So they're just going to feel a little bit of, maybe some lightheadedness, a little bit of syncope, as they put here. They might need to sit down real quick, and then that would generally be it. They won't have to do too much, right? So that's all you really see in people, and in everyday people who have insulin overproduction or over ingestion, if anything, right? Someone that injected too much insulin. But in here, things get far worse, right? But this little red period in between was actually the problematic area. So I wrote here, insulinoma will present with excess insulin, but hypoglycemia isn't as rigidly defined as hyperglycemia. Symptoms occur in 2 phases. First, the body has a minor panic attack at the 50 point, 50 milligrams per deciliter of glucose, and kicks up all the catabolic hormones like glucagon, cortisol, growth hormone, epinephrine, and most importantly epinephrine, which end up causing sympathetic hyperarousal, right? So this sympathetic hyperarousal right here, while this is happening, the amount of sugar is decreasing, right? Remember that the way this image is made, going towards the right is more glucose. So going this direction, you're having lesser glucose. So by the time you get to this second set of dots, this might be like 5 milligrams per deciliter, right? Very, very low, pretty much zero at that point. So in between here in this red period, these patients have now successfully made up for, or in effect masked, all the symptoms that they would have of hypoglycemia, right? But eventually all of that is going to run out. You're going to run out of glucagon, cortisol, and all the help you can get from epinephrine. The brain starts running out of energy, and this can now lead to coma, right? So literally you could jump from just feeling lethargy, syncope, and diplopia to all of a sudden going into decreased mental function, altered mental function, and then a coma, right? If you don't treat this, because all the brain can really use is just sugar. Symptomatic patients have low blood glucose and high C-peptide levels, which tells you that they're making a lot of insulin in themselves. It's not that they injected too much insulin. So that's the difference between checking for exogenous insulin use. So that's your basics of insulinoma. Very important to make sure that what you see is actually an insulinoma versus someone that might be doing like factitious disorder or something and injecting insulin to act sick. Now, this question about insulinomas tends to be very easy until they try to connect it to MEN syndrome, right? So 10% of these cases are actually associated with MEN syndrome, MEN 1, and 10% is a pretty big number. So when you do get one of these patients, the question might ask you about insulinoma. You might read the question. It might be very obvious it's insulinoma. And then at the very end of the question, just when you thought the question would ask you something where you could answer by saying, oh, it's an insulinoma, they'll tell it to you. They'll be like, turns out it was an insulinoma. And you'll be like, shit, now what are they going to ask? And then what they'll ask might be, what else would you look for? So you would look for anything else that might, help you think it's MEN1, help you confirm whether or not it is MEN1. You do need to rule out MEN1 since this is a really bad cancer, right? It's a neoplasia. So you can see here, pancreatic endocrine tumors, Zonger-Ellison, insulinoma, VIPoma, and glucagonomas are all things that you could see in MEN1. And when you do see that, you should check for parathyroid adenoma, so check for PTH and calcium, and any pituitary tumor. So you check for whether they have visual disturbance, if it's a big enough tumor, and whether or not they have any changes you would see from mainly prolactin or growth hormone. The acromegaly or the prolactin-induced decrease in libido, stuff like that. On top of that, MEN1 also tends to have angiofibromas, collagenomas, meningiomas. So if the question tells you that the patient has a history of meningioma and now today they're presenting with insulinoma, that's a big giveaway that this is very much most likely a person with MEN1, right? And this is actually the easiest one to remind you of that, but it also somehow tends to be the hardest one. Most people miss out the fact that meningioma, although you pronounce it meningioma, it has menin. It has menin in it, and menin is the main gene that's related to MEN1. So when you get a patient with meningioma, any patient, even if it is just a patient with meningioma and nothing else, you should immediately think this patient might have MEN1, right? And you should definitely spend a little bit of time ordering something to rule out MEN1, okay? Because you don't want those MEN1 things to occur. So they tell you here, best initial test, just check for fasting serum insulin, check for C-peptide, which should also be high. Most accurate test is a 72-hour fasting, where the patient would develop profound or symptomatic hypoglycemia because they have been fasting. Once the hypoglycemia is reached, labs drawn to determine etiology, and you're going to see that glucose, serum insulin level, C-peptide level, sulfonylurea, you get to check for all of these things. What you'll find is that the glucose levels are going to be low, serum insulin level and C-peptide are both going to be very high, and it's going to be a negative sulfonylurea screen, which means that the patient isn't eating. So remember, there's two ways to have you release insulin. Either you could inject extra insulin into you, at which point C-peptide would not go up, right? So you would not have high C-peptide, but you would have very high insulin. Or you could take excess sulfonylureas, which cause you to release a lot of insulin, thereby keeping insulin and C-peptide high. Now they can't tell that you're sick because of injecting too much insulin, right? So that's another thing that happens. So you want to see a negative sulfonylurea screen. The patient should not have been taking any sulfonylureas. You also check for serum beta-hydroxybutyrate, which is basically ketones, right? You're going to note that there's no ketones. Why? Because there's insulin present, right? Insulin stops you from making ketones. And serum cortisol level might be high because this is stressful to be fasting for 72 hours and becoming hypoglycemic. You're going to need the cortisol to kick in and, stand up to the stress. Once you see all of those things, you confirm that it's definitely some level of an insulinoma, and you do a surgery to resect it. Very easy to handle that. All right, same thing with VIPoma. So VIPoma producing tumor is highly malignant. Here we saw, let me go back to where it was. So they talk about all of them in the same page, insulinoma, glucagonoma, somatocytoma, Zonger-Ellison, and then the next page has VIPoma, a rare neuroendocrine tumor that secretes VIP. Most commonly arises in the pancreas and associated with MEN1. Primary symptom is diarrhea, but it's mainly associated with WDHA, watery diarrhea, hypokalemia, and achlorhydria, right, which the loss of potassium and loss of chlorine are related to the electrolyte imbalances we've been looking at. Right? So the stool sample will have a low stool osmotic gap because it's a secretory diarrhea. There's going to be a lot of water in it. Lab tests, high VIP levels, of course. Achlorhydria because VIP inhibits gastrin secretion. So without gastrin secretion, you're not going to have a CL secretion. So there's no CL, right? Hyperglycemia, hypercalcemia, and hypokalemia. Got to know this all. This is all going to be there in a question about a VIP. So the hardest way you can actually ask a question about VIPoma is about these lab tests, where they'll just, they'll put potassium, chloride, Na, and whatever else as a thing, and you're going to have all your up and down arrows, right? There's calcium. So yeah, this is all going to be low, right? Potassium is going to be low. Calcium is going to be high. Chlorine is going to be low. In these people, sodium levels will be normal for the most part. Nothing changes about that really. And yeah, just get it all down. You can of course do a CT and then just treat it by getting rid of it. Surgery to resect tumor. Now, here though, be very careful. You're going to get this as a question, and then in CK they'll be like, what's the next best step? And they'll have both answer choices. Replace fluid and electrolytes, or just do surgery, or give octreotide. They have all three of these answer choices in the question. Of course, all three answer choices are correct, but for the specific patient in that question, only one will be the next best step. Not, doing, of course, you're going to end up doing all three, but one of them is more important to do right away, and then you do the other two things. So if the patient has lost a lot of fluid and electrolytes, of course, the best answer will be to do that and replace it all. Right? And then surgery might actually be the last answer choice, but it could be the second thing. So if they've already done the replacing electrolytes in your question stem, then you could say, okay, prepare for surgery. After surgery, you could get the patient to take octreotide for some time, just in case, until things get normal, and then you take them off of octreotide and you monitor them again to see if anything recurred or did you get all the tumor out. Pancreatitis. So the hallmark finding in pancreatic cancer is a non-tender palpable gallbladder and jaundice, and this is a key thing we're going to come back to. That's all they wrote over here. But pancreatitis. So let's actually jump over to that. All right. So we have acute pancreatitis versus chronic pancreatitis. Coming back to step one, this was a very simple topic. In fact, the way the step one book even talks about it, they kind of make it look like they're the same thing and just one is acute, the other is chronic. So here we see acute pancreatitis. You get images like these a lot. Images A and B are clearly substantially different from each other. These images weren't always in first aid, and they're great to have there now. They're very helpful. Acute pancreatitis causes autodigestion of the pancreas by pancreatic enzymes, right? So image A is showing you the pancreas surrounded by edema, right? So the edema is the darker portions around it. There's darker portions, you can see it on your book very clearly, lining the actual pancreas inside. Why is there edema around it? Because it's inflamed, and that's what happens when any organ is inflamed. Why is it having autodigestion of the pancreas? Because you probably blocked the ampulla vator, where the pancreatic secretions would come out, so the secretions ended up staying in the pancreas, and now it's causing digestion of the pancreas itself. There are many causes. It could occur for no reason whatsoever, idiopathic. Could be due to gallstones, alcohol, trauma, steroids, mumps. Autoimmune disease is very vague, so don't worry about that one. Scorpion sting, which is very specific, right? Hypercalcemia, and more importantly, hypertriglyceridemia, ERCP, and then some drugs. Mainly, I would say that you should watch out for the NRTIs and protease inhibitors, because those two have many side effects, but the most important one that often gets tested is that they can get pancreatitis. So as you can see, there's a lot of room for reasons to test you on pancreatitis. Diagnosis is by 2 of 3 criteria: either acute epigastric pain, often radiating to the back, high serum amylase or lipase, but the lipase is more specific. When you have a patient with very high lipase, that's more specific to pancreatitis. So high that it could be 3 times the upper limit of normal, or characteristic image findings like this. Complications could be a pseudocyst, and then that's what they're showing you in image B. So in image B, what you see is you still have the same pancreas. That's your pancreas right there. You still have it here, okay? But now what you're seeing is this really big, right? This is really big and really, really wide, right? Cyst on both sides around the pancreas. This is really huge. And of course, you're going to feel this on the patient's abdominal palpation and everything. And it's a pseudocyst. It's not a real cyst because it's actually lined by granulation tissue, not epithelium, right? Not epithelium. So that's why it's called a pseudocyst. So oftentimes the answer choice is actually going to list it out like that. It'll be like you're going to find granulation tissue surrounding the pancreas. So for you to pick pseudocyst, usually the only way to actually pick that as an answer choice is if they give you the imaging. They have to give you imaging that shows you a huge thing like this that actually looks like a liver now, but it's on the left side. And this is the left side of the patient. And so this is a huge pancreas now because of the pseudocyst. So It's a thing that can occur due to acute pancreatitis. And then, of course, you could note abscess, necrosis, hemorrhage, infection, even organ failure, hypocalcemia due to calcium soaps. This is actually pretty commonly tested, calcium soaps forming because of autodigestion of the pancreas. And the enzyme responsible for acute necrotizing pancreatitis is trypsin. You need to remember that too. Right, trypsin, because trypsin and trypsinogen act in a positive feedback loop, which causes more trypsin to activate, all of which ends up causing acute necrotizing pancreatitis. So these are the key topics that I saw when I was studying for acute pancreatitis. They all show up, they all pop up in questions. And then chronic pancreatitis is just chronic inflammation, atrophy, and calcification of the pancreas. So now what you notice in the same pancreatic image is that it has these white pebbles on it, which is calcification. Once you start seeing the calcification, it's chronic. Right? Major causes include alcohol abuse and genetic predisposition like cystic fibrosis. Can be idiopathic, which is whatever. Complications include pancreatic insufficiency and pseudocysts once again. Pancreatic insufficiency, typically when less than 10% of the pancreatic function is actually there, may manifest with steatorrhea because you're not going to be able to absorb your steatorrhea because you're not going to be able to digest food, and because of that, you're not going to be able to absorb your fat-soluble vitamins. You could also end up getting diabetes now that the pancreas is not going to work anymore. Right? Amylase and lipase may or may not be elevated, almost always elevated in acute pancreatitis, but not necessarily elevated anymore in chronic pancreatitis. So now if we come back and compare to here, acute pancreatitis says leakage of activated pancreatic enzymes into the pancreatic and peripancreatic tissue, which then causes autodigestion. Time course is abrupt onset of severe pain, usually epigastric and radiating to the back, as we complete it. Right? So the things I'm saying are the things we don't see here, but we just read it. Etiology, same ones, nothing new. Same etiologies we just saw back on step 1 book. History, severe epigastric pain radiating to the back, nausea, vomiting, weakness, fever, shock, pleural effusion, and even ARDS. Pancreatitis is one of the things that can cause ARDS, as you see when you do respiratory. You might note the Gray Turner sign, which is a new thing here, or the Cullen sign, both of which are new things here. Gray Turner sign is flank bruising in the flanks. Well, you'll just have it on one side, the left one, where the pancreas is. And periumbilical discoloration, and both of which are weird things that you don't really see that often. Unilateral left side flank is bruised, and you have periumbilical discoloration. These are things that are giveaways that the patient might have acute pancreatitis. Definitely look for the elevated lipase, but you might just see elevated amylase. It could be either. And you could start noticing decreased calcium if it's severe. Then they have these new things here. They have the sentinel loop or the colon cutoff sign on X-ray of the abdomen. Right, but they don't show you that here. So these are things that you Google an image for it, check it out, see how it looks like, and then you'll know. Ultrasound of the abdomen or CT may show an enlarged pancreas with peripancreatic fluid and fat stranding, abscess, hemorrhage, necrosis, or pseudocyst. So let's take a quick second to Google this and see how this stuff looks, right? So first one, we have sentinel loop pancreatitis. So I'm going to put it in the book so you guys can see. Okay, so sentinel loop. Let's see a good picture for that. Oh, that's what they're talking about. That's pretty weird. So for sentinel loop, this is the image that pops up, and I'll tell you what it says. So this is the image that shows up, right? This is what they're showing you, and they have the ST right there. You see the stuff they have inserted is taking this weird curve. Let's read what it says. So here they say, Oh, the other thing was called the cutoff sign? Colon cutoff sign. Oh, these are both actually the same thing. Right? Sentinel loop or colon cutoff sign are apparently two names for the same thing. And that's what this looks like. Right? Seen in acute pancreatitis. A single dilated jejunal loop in the upper abdomen. Right? That's what we're seeing here. This. Okay, single dilated jejunal loop in the upper abdomen. Colon cutoff, they write, is dilated colon to the mid-transverse colon with no air seen beyond the splenic flexure. This is due to extension of inflammation along the mesocolon. Could lead to diffuse ileus, small bowel dilatation, which is the most common apparently. Right, so this is on a website, lumen.luc.edu. This is pretty cool to see. I haven't looked at this before, but the web page is actually showing really good images, so this would definitely worth checking. So all I really did was I googled sentinel loop pancreatitis, and the first picture that showed up was this picture, and this picture is related to lumen.luc.edu, and they have wonderful pictures to further break down what all of this is and why you would see it. Next, treatment. Removal of the offending agent, whatever it is that might be causing the pancreatitis. And then supportive care, IV fluids, electrolyte replacement, all the obvious things, right? But remember, although these are quote-unquote obvious things, many people don't tend to think of them, so you want to make sure you definitely at least read it once and understand that these would be things the patient would need. Infected pancreatic necrosis should be treated with antibiotics, though prophylactic antibiotics are not recommended. So if you don't see infection, don't just give antibiotics. If you do see infection, though, then of course use it. Endoscopic, percutaneous, or surgical debridement may be considered. Prognosis is pretty good. 85 to 90% are mild and self-limited. 10 to 15 are severe, requiring ICU admission. Mortality may approach 50% in the very severe cases, which, again, that part sucks, but usually it's okay. Complications are the pseudocysts. So here we see different images, right? But again, generally the same stuff, right? So here, this is just the pancreas with a thick lining, so that's pancreatitis. Here's the pancreas with the white pebbling on it, so it's chronic. And that's what you're seeing. So images, where do they label it? Oh, I think they have it back up here. Yeah. I don't know where they labeled what these images are supposed to be, but that is what they're supposed to be. Right, so this is just pancreatitis, and this is the chronic pancreatitis. So let's look at the chronic pancreatitis. Now, chronic has irreversible parenchymal destruction, leading to pancreatic dysfunction and insufficiency. So now it's irreversible. Persistent recurrent episodes. Alcohol abuse is the #1 cause. Cystic fibrosis is the #1 inherited cause. Pancreatic divism can also lead to it, which is a neonatal issue during development. Recurrent episodes of persistent epigastric pain, anorexia, constipation, flatulence, diarrhea, weight loss, and DM. That's very different history-wise, right, and presentation-wise, because here with the acute stuff is acute, so this is day one, the patient shows up with all of this sudden epigastric pain going to the back. That's when you immediately just put them down and check what's happening, right, because it's pancreatitis. Here, diagnosis-wise, the enzyme levels could actually be normal. You may also note decreased stool elastase, worth keeping that in mind. That could be a weird answer choice that might be off, that might catch you off guard. We already saw the pancreatic calcification, which is image B. Okay, so right here, image B and image A, right? Image A is your ultrasound of the abdomen with pancreas with peripancreatic fluid and fat stranding. So that's acute pancreatitis. Besides the pancreatic calcification, you could also note alternating stenosis and dilatation. That's the arrowheads. Really hard to see. I'm not sure what they're talking about there. But apparently there's going to be alternating stenosis and dilation of the main pancreatic duct on CT or ultrasound, also known as chain of lakes. Okay. Treatment, generally the same stuff. Analgesia, pancreatic enzyme replacement, avoiding anything that could further worsen this. Celiac nerve block is one new thing here. Right, and then endoscopic dilation of the pancreatic duct, surgery for intractable pain or structural causes. Patients can have chronic pain or pancreatic dysfunction. Chronic pain, opiate addiction, diabetes, malnutrition, splenic vein thrombosis, and pancreatic cancer are potential complications. The worst of which being pancreatic cancer, which is usually fatal. And patients that present with pancreatic cancer, all of a sudden, even though they haven't had a history of pancreatitis, by the time you can find out they have pancreatic cancer, it usually means that it's become symptomatic, which means it's become to a point where they're probably just going to die now. Right? It's too far gone. So that's what they're talking about right here. Pancreatic cancer. Most, 75%, are adenocarcinomas. of the pancreas. Risk factors include smoking, chronic pancreatitis, and first-degree relative with pancreatic cancer. Incidence increases after 45 years of age, slightly more common in men. All right, not so bad. Presentation, abdominal pain radiating to the back, just like pancreatitis. But they also get obstructive jaundice because their bile duct is going to be messed up, especially when the cancer is of the pancreatic head. Loss of appetite, nausea, reflex symptom of weight loss, and then indigestion because they're not going to release pancreatic enzymes anymore. Often asymptomatic, which is the worst part here. And often asymptomatic, and thus presents late in the disease. So by the time it presents, there's nothing you could do about it. Right? It'd be much better if you could screen regularly and find it. But I don't think we do. Yeah, we don't do regular screening for pancreatic cancer. I don't think it's common enough, but I feel like it should still be a thing that just a one-time regular screening should occur. But as you can see, they don't talk about screening here because it's not really something you do. All right. In some patients, depression may be the most prominent symptom. Right? Because of course you start feeling pretty depressed when you start acting like you have loss of appetite, nausea, weight loss, weakness, fatigue. Right? These are starting to sound a lot like the SIGI caps of depression. PE, physical exam, may reveal a palpable non-tender gallbladder or migratory thrombophlebitis. This was one of the biggest things back in step 1. They loved talking about this. Right? Migratory thrombophlebitis, which is indicative of the fact that you might have some occult malignancy. It's basically your body telling you something's wrong. Let me see where they talk about it now. Thrombophlebitis. Oh, well, it's okay. We're here already. Excuse me. We're already on the pancreatic adenocarcinoma page. So right here they mention it. Right? Migratory thrombophlebitis, which is redness and tenderness on palpation of the extremities, aka Trousseau syndrome. And very important to understand when you see that this is related to a person having pancreatic cancer. This is what you see in this question too. So look, 29-year-old woman, G1P0, so she has a child. At 11 weeks gestation, comes to the physician because of a 2-day history of left lower extremity pain and swelling. Her temperature is 100.2. Physical exam shows a tender palpable cord on the lateral aspect of the left lower leg. That is thrombophlebitis. The overlying skin is erythematous and indurated. Duplex ultrasound shows vascular wall thickening and subcutaneous edema. Which of the following was the most likely diagnosis? And they had all these answer choices. A variant of this patient's condition is called Trousseau syndrome, in which palpable tender cords recur at different locations on the body. Her thing is superficial thrombophlebitis, which is usually a benign inflammation of veins and overlying tissue due to thrombosis, which can occur in a pregnant woman. The inflamed veins impacted with thrombotic material manifest as palpable nodular cords that remain visible when the limb is raised. There is a greater risk of thrombosis during pregnancy due to a combination of hypercoagulability and elevated venous stasis because they're pregnant and they're not moving much, right? Compression of enlarged uterus on pelvic veins. That is different from what you have here. Right? Just a superficial thrombophlebitis is one thing. When it starts showing up in different parts of the body and becomes quote-unquote migratory, that's a different variation of the same thing. That is due to hypercoagulation in your entire body due to a systemic cancer. So be very careful not to confuse yourself. For this question down here, most people did pick DVT. Because again, that's another thing that can occur when you're pregnant as well. But her thing wasn't DVT in this question. She wasn't having DVT symptoms per se. It's a very important thing to watch out for in all your questions. Best initial test, CT scan with contrast, localize the tumor, assess the local invasion and distant metastases. Ultrasound of the abdomen is the initial test of choice if the patient is suspected to have pancreatic cancer. If a mass is not visualized, use ERCP to check more closely. CA19-9 is the thing that will be elevated, but is neither sensitive nor specific. But as far as step 1 is concerned, it's pretty specific. If your step 1 question mentions CA19-9, if your step 2 CK question mentions CA19-9, they're talking about pancreatic cancer. And this might not be always the case in real life, but on the test it is. So again, there's no screening mechanism. Right? There's nothing you do to regularly check someone if they've developed pancreatic cancer. Right? You probably have some level of a screening mechanism for people who have a history of pancreatic cancer in their family, but not for everyone. Treatment is pretty obvious. If it's locally advanced or metastatic disease, most frequent presentation, then you just do palliative chemotherapy and hope it works out. Because once it's advanced or metastatic disease has occurred, chances are the patient is going to die. This is the most frequent presentation because usually pancreatic cancer is actually asymptomatic. Small tumors in the pancreatic head with no metastases or major vessel involvement, you just do a Whipple procedure, which is pancreatic duodenectomy. Whipple procedure is literally cutting out distal stomach, first and second portion of the duodenum, head of the pancreas, common bile duct, and the gallbladder. You just remove all of that. Right, so that takes care of any part that might have some of the cancer in it. Tumors in the body or tail of the pancreas with no metastases or celiac artery involvement, distal pancreatomy and splenectomy, because you need to get rid of anywhere where there might have been some level of metastasis. Right, and then of course, unfortunately for real life presentations, these two things don't occur. It's very rare that a patient presents with one of these two scenarios. Chemotherapy with 5-fluorouracil and gemcitabine may improve short-term survival, but long-term prognosis is pretty poor. At 5 to 10% 5-year survival. Okay, so that's generally it for that. That wraps up GIT. And now that brings us to hematology and oncology, which is an extremely long and in-depth chapter. While we do hematology and oncology, before we even jump into here, because in the CK book, they don't take any time really explaining this or really revising any of the, they mention it one more time, but they don't really revise any of these guys that much. So it's very important to make sure that we have ample revision of the various coagulation factors, primary and secondary hemostasis, how they work, the key players of hemostasis, which means basically revising hematological pharmacology. So you remember that the pharm section here is first going to talk to you about all the heme stuff, right? All the heme stuff, and then comes your chemo stuff. Right, cancer drugs and chemotox and all that. But very important to revise the heme stuff first, separately. You really want to train yourself to study this chapter as 2 individual chapters rather than just one. Okay, so we're gonna first talk about all the different coagulation cascade things. We're gonna talk about primary and secondary hemostasis. We're gonna revise heme pharmacology from step 1, and then we'll dive into looking at the various diseases, right, starting with hemophilia. So we'll do all of these things in the next video, where we're going to really just rapidly go through a good revision of hematology and then jump into how you're supposed to manage these patients in the CK world.